Hi, and welcome to another episode of the Princeton Spine Joint Center podcast. My name is Scott Curtis. I'm the Director of Sports Medicine here at the practice. I just had a great conversation with Nicole Groszew Mattonelli from Professional Physical Therapy here in Princeton. She is an orthopedic physical therapist and a sports-specific physical therapist who has a wealth of knowledge on different types of sports-specific physical therapy protocols. We talked about a lot of different things, talked about generalized physical therapy, what it is, and what are some of the expectations behind physical therapy. We also talked about sport-specific physical therapy and a functional progression to getting an athlete back to doing what they want to do. And we use the example of runners of sport-specific injuries and different ways that we could get them back to running. So if you've ever done physical therapy or are an athlete who has had chronic or acute injuries that required physical therapy, I really hope you enjoy this episode. Hello, and welcome to this episode of the Princeton Spine Joint Center podcast. My name is Scott Curtis. I am the Director of Sports Medicine here at the practice. I'm joined today by Nicole Groszew Mattonelli from Professional Physical Therapy here in Princeton. Nicole earned her doctorate of physical therapy at UMD&J, and she specializes in orthopedic physical therapy and sports-specific physical therapy. Nicole, thank you for joining us.
Thanks
Appreciate
for having
me. So you're our very first physical therapist here on the podcast.
Yes.
And so before we kind of talk about the sports-specific physical therapy, which is kind of the focus of today's episode, let's just talk about physical therapy in general.
Sure.
So what exactly is physical therapy?
So I think looking at physical therapy, I like to think about it as us being like movement specialists.
Okay.
So we're able to look at movement and dysfunction. So if you're having pain with movement, joint pain, back pain, all of these things can be addressed in like a comprehensive evaluation, taking a look at joint strength, things of that nature, just to help assess what is going on, what is the root cause of your dysfunction and pain.
Okay. And then following the assessment, that's when you come and do an actual plan to fix the dysfunction.
Right, exactly. So what we would do is create like a comprehensive treatment plan based off of our findings of the evaluation, and create a plan that's tailored to specific to the person and the dysfunction to address any issues that are going on.
Yeah. I mean, as a physician, physical therapy is one of the most important tools that I have. You know, it's kind of like a carpenter's hammer. A sports-specific or sports medicine physician has physical therapy as one of the assessment and treatment tools. So it's super important, something that we often will prescribe. And I think it's really important for patients to understand exactly what physical therapy is and why are we doing it.
Right.
A lot of times I'll have patients who say, I've done physical therapy in the past, it doesn't work, it doesn't help. How do you kind of respond to that?
So I think the challenge in, any of this is that I like to think that we're different. And it's tailored to what is wrong with the person. So we're going to take a look at the whole person, not just the low back pain or the knee pain. And it's not a cookie cutter approach. So we need to listen to the patient about what is going on to help tailor a treatment program. So I think that's sort of the difference as well. In just creating like a good plan for the patient.
Yeah, absolutely. I mean, I always say you're a person. You're not just the back pain. You're not just knee arthritis. Everything is connected. You're a whole body.
Right.
You're not just the sum of the parts. But a lot of patients will have back issues, knee issues, shoulder issues. How do you kind of address one thing or prioritize, I should say, one issue over another? Or do you kind of go through a little bit of everything on each session? How do you kind of go about doing that?
So let's clarify. You mean if one person's coming in with like several different complaints?
Yeah.
Okay. So what I'll do is I'll sort of triage the situation by what is the worst thing going on right now. But in treating somebody's lumbar spine and knee, like it's a whole kinetic chain.
Sure.
So if somebody's going to come in with knee pain, I'm not just going to treat knee pain.
Right.
Everything is attached to everything else in our bodies. So strengthening up the kinetic chain, which means the hips and the core. Same with down the chain into the foot intrinsics and proprioceptors of the ankle would be part of the treatment plan just to treat one joint.
Okay.
So taking a whole body approach is going to help treating somebody who comes in with multiple different complaints.
Gotcha.
That being said, though, you also have somebody, if they come in with like an ankle and shoulder, those are two specific things that you would create a treatment plan for both of those things and address everything in one visit.
So a lot of times I'll see a patient who has back issues, and then they also have some underlying knee arthritis that got worse because they're compensating.
Sure.
Or vice versa. They have underlying knee problems, they're offloading the joint, and then they start to develop hip issues or low back issues.
Sure.
Does it matter necessarily in your mind what the chicken is versus the egg, what the underlying issue versus the compensatory problem?
I think I always try to look at what the driver of the symptoms are, because you want to see if you can like effectively treat what is driving your pain and symptoms first.
Okay.
But that being said, patients like don't need to live in pain either.
Right.
So trying to triage that and treat both while trying to really underline and find the driver of what the symptoms are.
Yeah, I completely agree. So you'll have, so let's say I have, we'll just talk about a generalized patient at this point.
Sure.
With low back symptoms. He's in significant pain, but we're trying to control it with, let's say, medications.
Sure.
What is the kind of assessment that you'll start to do on the first day?
On the first visit, so any patient who comes in with complaints of low back pain, I'll do a neurological assessment on them. Sensation, reflexes, upper motor neuron signs, and strength, just to see if there's any sort of loss of strength or sensory changes in a myotomal pattern.
Okay.
Then I'll also just take a look at what sort of the driver of the pain is. Do I think it's facet-mediated pain, a strain, discogenic pain, and sort of tease out what exactly the driver of the pain and symptoms is on the first visit so that I can effectively come up with like a treatment plan. Especially with low back pain, I'll also look at if there's like a directional preference because if there is, oftentimes you can prescribe some exercises based on their directional preference. That's kind of like their go-to for immediate relief.
Yeah, that makes a whole lot of sense. I think it's important, especially for patients who have never done physical therapy at all, to kind of set the expectations, especially on the first day, because a lot of patients will hear from, friends or relatives that they're going there to exercise. And so they're going in there, they will kind of not realize that there's a whole assessment process on the first day and will be somewhat disappointed after the first day because they didn't start doing the exercises right away. So what are some of the expectations that we should, both as a physician and a physical therapist, lay out for the patient when we start physical therapy?
So I think it might vary a little bit depending on the physical therapist. But for me, on the evaluation, I'm always going to do like a full comprehensive exam, outline the plan, do some sort of manual intervention just to see how they're going to respond to manual therapy, whether it's traction, manual traction, or some sort of trigger point release, soft tissue, Graston or cupping, and a home exercise program, depending on the acuity of the pain. So it's all going to depend on the patient too. But 9 times out of 10, my patients are getting a home exercise program, starting some exercises in the clinic that day, and getting a trial of manual therapy.
I think that's a good initial assessment and a good approach to kind of introduce some exercises at home. I think one of the frustrating aspects of physical therapy that a lot of patients will find is that it takes long. It's a lengthy process, right? Everybody wants the quick fix, the magic bullet. They want the pill, the injection, and sometimes that's appropriate to do those kind of things. But I'll often say that the pill or the injection in most cases are just designed to get your pain under control.
Right.
But once that pain is under reasonable control, then we have to start the long-term work and the chronic plan to keep you out of pain.
Sure.
And for me, that involves a strengthening program, a stretching program, a physical therapy with a transition to home exercises.
Right.
So, and this is certainly individualized, but what's a realistic time course that you find that physical therapy is appropriate for most patients?
Like the estimated like length of time that they might be in rehab.
Yeah.
So it's gonna vary on like if neurological symptoms are involved, but like anywhere from 6 to 12 weeks.
Okay.
Of course, excluding like any postoperative
Sure.
diagnoses or something like that.
Yeah, well, let's hold off on the operative stuff because we do non-operative stuff.
True.
But of course, we'll refer to surgeons, and then they'll have their own post-operative type of protocol. But I think in terms of a treatment line prior to surgery,
Sure.
whether it's with injections, with medication, in conjunction with things like other modalities such as acupuncture or chiropractic, I usually tell patients you're not going to see significant and meaningful results to at least 4 weeks.
Yeah, I think. Oh, you're talking about results. I thought you were just talking about plan.
Well,
okay.
yeah. Just
I think our sort of rule of thumb is we want to see some sort of improvement in the first 3 to 4 visits. And it's going to vary for everybody.
Yeah.
And it might just be maybe I can stand for 10 more minutes or maybe I can walk a little bit longer.
Sure.
So we're looking for some sort of small changes, but some like interval improvement in the 3 to 4 visit mark.
Okay.
But I think for significant relief, it is usually around like the 3 to 4 week mark.
Yeah, because you're following up much more frequently with the patient than I am.
Sure.
So, patients will, if I prescribe physical therapy, they'll say, okay, should I come back in 2 weeks? I'll often say, you can come back in 2 weeks, but from my perspective, I'm not sure we're going to see a significant improvement in pain, your strength, your flexibility. We'll see some improvement, but usually I'll have them come 4 to 6 weeks after I prescribe the physical therapy.
Right, especially if they're like very acute.
Yeah.
You still have a whole inflammatory process going on.
Sure.
So having a realistic expectation too on the first visit helps patients sort of buy in and sort of stay compliant on their program too.
I think that's half the battle is setting the expectations and making sure that there's direct communication between the doctor, the therapist, and the patient, and sometimes the patient's families, so that everybody's on the same page and say, okay, this is our assessment, this is our plan, this is what we expect within 2 weeks, 4 weeks, 6 weeks, and so on and so forth.
Right.
And obviously things are going to change, and that's where you and I will have more of a conversation as practitioners, and then relay that information to the patient.
Sure.
A lot of times I'll tell patients that there's 3 benefits of physical therapy, just generalized.
Sure.
One is if you have a lack of strength. So if your weakness, getting the muscles stronger is certainly one reason to do physical therapy.
Sure.
2 is flexibility. So that's a huge, whether that's the primary or compensatory sign that's causing pain, I think flexibility is another issue that should be addressed. And 3 is pain control, right, with a lot of different modalities.
Yeah.
Is there anything that I'm missing from a therapist perspective that maybe I should be highlighting to my patient?
I mean, so the other thing that I look at, and I think it can be challenging to explain to the patient, but it's also like motor control.
Yeah.
So strength is great.
Right.
But we also need the muscles firing sort of the way that they were designed to do in order for the mechanics to be sort of correct.
Right. So do you have an example that's pretty commonly seen?
Multifidi, actually.
Okay.
Oftentimes this will be like inhibited on a patient, multifidi in both transverse abdominis, right?
Right. So those are what kind of muscles are those?
Those are core muscles.
Yeah, patients that don't know what those are.
The transverse abdominis is the deepest abdominal muscle. Then you have the multifidi, which are small like back rotator muscles. And oftentimes, especially in back pain, these muscles will become inhibited.
Right.
Those 2 muscles work in conjunction to help sort of stabilize the spine. I tell people they kind of act like a corset and really protect the spine when you're doing any sort of lifting, twisting, rotational movements. And if those things aren't firing properly, you can get facet impingement, you can get rotary movement and sort of flare a disc up. So it's really important to sort of retrain those smaller muscle groups before thinking about those larger muscle groups.
Yeah, and the classic example that I have is I see a ton of, very active individuals who go to the gym regularly, who have back pain, and they say, I'm strong. I do sit-ups all the time.
Yeah.
I bench press and I do a lot of, back lifting. Why do I need therapy? And I try to explain to them that, yes, when you go to the gym, you're working out the big muscle groups, but it's the small muscle groups that are responsible for, maintaining or decreasing some of the load off the spine.
Sure.
And those are the ones that we need to start working on. Sure. And sometimes, especially for those who are resistant for a 6-week period or an 8-week period of PT, I'll oftentimes just go 1 or 2 times so that you could be evaluated, and then start getting the home exercise program. Make sure you're doing them well, and then check in every couple of weeks with the therapist.
Absolutely.
Do you think, from your perspective, that's a reasonable approach for some patients?
For some patients, absolutely.
Yeah.
The patients who are active, who they'll be compliant with their program, that's absolutely an alternative.
Yeah.
That being said, there are also patients who are not compliant with their programs.
Correct.
And strengthening in sort of the beginning phase, you really want to be strengthening 4 to 5 times per week.
Yeah, absolutely.
Especially if we're looking to make some changes in strength. So I have patients who tell me, I don't know that I'm really going to do my program at home. And I'm like,
absolutely.
well, then if you're not going to be accountable to do it yourself, then that you want to make sure that you're getting into your physical therapy.
Yeah, and that's a great point. I'll often prescribe physical therapy, and I'll have a realistic conversation with the patient. I'm like, listen, don't lie to me and tell me you're going to do these if you're not going to.
Right.
If you're not going to do it, be honest, and then we'll come up with a way that we can do it. And even getting them into therapy so that they're held accountable, so that they're actually doing the work is super important. But you also have to know your patient.
Sure.
You have to know what resources they have. Are they able to drive to a physical therapy place or not? Are they going to be motivated? Are they going to be compliant? Those are all kind of judgment calls, and getting to know your patient, and hopefully, having an honest conversation as the practitioner and the patient. But sometimes it is challenging to motivate people.
Yes.
Especially when you start talking about in terms of treatment plans for weeks and months,
Sure.
as opposed to, days that you're going to be on a medication or something like that.
Sure.
But it's super important nonetheless. How important in your mind is it to maintain the home exercises after therapy is over?
Very important. Unless you're going to transition into some other extracurricular, incorporating some of the same strengthening at the gym, or getting into a mat Pilates or a yoga program, more specifically for patients with low back pain for core strengthening stabilization. But you can't go from exercising 4 to 5 times a week,
right,
and then if you live a fairly sedentary lifestyle, do nothing and expect the carryover.
Yeah, I completely agree.
Yeah.
I'll tell patients the most important part of physical therapy is actually after the physical therapy.
Yeah.
Because a lot of patients will feel great during PT or towards the end of PT. Pain is gone, they're feeling stronger, they're feeling more flexible. And I say that's fantastic. But if you go home and do nothing and you don't maintain the exercises, you're going to lose everything you've gained over the past 6 to 8 weeks.
Yes.
And so I'll really, really harp on the home exercises. You don't have to do them every day, for an hour every day. That's a whole lot of time.
Right.
But, 10 minutes, 15 minutes, take 2 or 3 exercises, really dedicate them every other day.
Yeah.
Switch it up, I think, is really the difference between coming back in a few months and saying, my pain is back, I need a shot, I need to go back to PT,
right,
or maintaining an active lifestyle and not having to get an intervention any further.
Right. And sort of that being said, too, when coming up with a discharge home exercise program, I try to keep them shorter, just sort of the most bang for your buck exercises and the most important.
Sure.
I mean, if we're prescribing an exercise, it's important.
Of course, yeah.
But trying to hit the muscle groups that we're not sort of getting
Sure.
on a daily basis if we're like walking or going upstairs or things like that.
Yeah, I'll do a lot of exercise counseling on patients before and after physical therapy, and I think it's super important to maintain the home exercises.
Yeah.
So we've been talking about just generalized physical therapy. Your specialties in orthopedics and my specialties in sports medicine. So let's kind of shift to sports-specific physical therapy.
Sure.
So when I write a prescription for sports-specific physical therapy, how does that differ from just regular physical therapy?
So I think what we're looking at is the specific patient and the athlete,
Okay.
and sort of the demands of their sport and how it's going to apply to how we need to rehab them.
Okay.
So just in terms of like any sort of athlete who's going to require like plyometric or stabilization exercises, we're going to sort of look at that and incorporate those sort of activities into their program because we want to stress the tissues in rehab like they would be out in their sports-specific activity.
Perfect. I couldn't have said it better myself. I think it's important to kind of simulate the activities that they're going to be doing that they want to get back to that they may not be fully ready for, but to simulate that in a controlled environment, to make any kind of corrections and kind of build up some of their endurance and stamina in order to do those. I'll often see baseball players or football players with shoulder issues that they're not ready to throw a ball yet. So you have to kind of do a sports-specific or functional progression back to throwing activities. And there's a lot of different ways that can be done.
So piggybacking off that too, you want to look at their mechanics.
Yeah.
So how did they end up with shoulder or elbow pain in the first place? So is there, and a lot of times I'll see there's not enough thoracic mobility maybe, or in other cases for however reason he didn't have enough external rotation at the shoulder. So all of those things are going to sort of go into why they're having the pain now. So we need to sort of look at the whole athlete and just break down the mechanics.
Yeah, so one of the examples that I'll often use and are runners. We see runners all the time. I know you see runners a lot. Actually, your physical therapy group, I think, is sponsoring the Princeton Half Marathon in November, right?
Yep.
And so let's talk a little bit about running specific issues.
Sure.
When I see a runner, and runners could be anywhere between, running a mile a day to running 10 miles a day, training for a marathon.
Sure.
I'll often look at why did this patient get injured? And what are some risk factors that we could identify? And if the risk factor is identified and we can modify it, let's modify it. But there's got to be a reason why that person got injured in the first place. So, for example, I saw a 40-year-old training for a marathon that's going to be coming up in the fall, started to develop knee pain. We did some x-rays. It actually wasn't, terrible in terms of degeneration. When I examined him, his patella was just moving all over the place. And so chondromalacia patellae or patellofemoral pain syndrome was a diagnosis. I prescribed him physical therapy and, counseled him on a couple of different things. What's your approach when I send him to your office with a sports-specific physical therapy prescription for a runner's knee?
So I'm going to look at several different things. First, I'm going to look, especially runners. Actually, this really goes for any patient with knee pain. I'm going to take a look at their feet. Okay. And are they in the right shoe wear? Yeah. Most people have some sort of pronation deformity, so flattened arch. Okay. And that is going to affect the knee significantly. Sure. Because it's going to lead to sort of valgus, it can tension the IT band. It's going to affect sort of the glide of the patellofemoral joint. So that right there could tell you just 1,000 things about what is going on with them. So are they in the right shoe wear? Some people are not. Especially if they're new to running, they're not going to be in the right footwear. So either trialing some taping and orthotic and getting them into the right shoes is going to help with that. And then we want to take a look at their running mechanics. Where are they striking? Are they a heel striker? Are they a forefoot striker? And then what does their hip and core strength look like? Okay.
Yeah, so there's a lot of different risk factors that I look for. And one of my mentors said if you have a runner, they should be barefoot and they should be walking around before you can even make any kind of assessment.
Yeah.
Because, like you're saying, most people will not have the perfect foot, right?
Right.
Some people will pronate, meaning their feet kind of come inwards. Some people will supinate, it goes outwards. Some people have high arches, low arches.
Right.
It's so important to look at that. That way you can make recommendations on footwear, as you're saying.
Right.
And there's a lot of controversy on footwear. Not controversy, but there's a lot of disagreement, I would say, about footwear. And mostly, should you have kind of the flimsy, soft shoes, kind of the minimalist type runner shoe, or the more supportive shoe?
Right.
There's I don't know if you ever got a chance to read it. There's a great book called Born to Run, which talks about, the native tribe in Mexico. They're, long distance runners. They run barefoot, and the author's take is that we should be running like that, how cavemen used to run.
Yeah.
I actually disagree with that 100%. I think that you need to have more of a thicker shoe when running. One that you can't easily bend in half.
Yeah.
Because every time you strike the ground, force from the ground is going to translate up. And if you have no barrier, it's going to translate up and cause injury. What is your thought on that?
It's kind of a loaded question.
Sure.
Because I think as a society, we spend a lot of time in shoes which have support.
Yeah.
So we don't have the intrinsic strength or control in the foot. So I think it can be trainable, but I also don't think it's for everybody.
Yeah.
So I think if you want to be in a minimalist shoe, that's going to require some intrinsic training and strength.
Sure.
To sort of retrain your foot to adapt to that sort of load. But you're right. The foot was designed with all of these small bones in it for shock absorption.
Yeah.
So if we're not properly absorbing the shock as we're running, it's going to translate to knee, hip, back issues.
Yeah, I mean, it's a generalized rule in my opinion. Everybody's different, and some people are much better in a minimalist shoe. I've had patients say, look, I spent hundreds of dollars on Brooks or Asics or these really sturdy shoes, and my pain got worse. And then I switched to the Nike Freeze or the frog type shoes, and my pain went away. I say, all right, so stick with whichever one is making you feel better.
Right.
That's an important risk factor to identify. A lot of times I'll recommend them going to a running store.
Yes.
Because they'll often put you on a treadmill. They'll watch you walk. They'll watch you run. You could try out different shoes.
Yeah.
It's better than shopping online and not even trying the shoes out and then deciding you're going to train for a marathon.
Right. And that's sort of what I love too about I do a navicular lift taping. So it helps to support the arch.
Okay.
And we can sort of do this for a couple visits, engage the patient's response about do they need an orthotic or what type of shoe should they be in.
Right.
Because it would sort of just indicate if a motion control shoe would be better for, them and their impairment.
Yeah. It's not just the foot itself and the footwear. A lot of times we'll talk about orthotics, the pros and cons of that, pros and cons of over-the-counter versus custom orthotics made by a podiatrist. But to me, there's other risk factors, the surface that you run on and the amount of miles that you're doing. So when you have an athlete come in for therapy, how do you train them to run on different surfaces?
So we'll work on different proprioceptive things first.
Okay.
So static and dynamic balance on different types of surfaces.
Okay, cool.
I'll do some treadmill training in the clinic.
Yeah.
But it's more about getting their dynamic stability or static and dynamic stability to be good first.
Okay.
On a varied types of surfaces so that it can translate out into wherever they're deciding to run, whether it's a track or asphalt. Or
I'll see a lot of athletes in the springtime come in with issues, and primarily because they've been running all winter on a treadmill, which is a softer surface. The weather's starting to get nice again, so they go out on the asphalt or the trails, and then their pain starts coming back. And so we'll often have to talk about different surfaces and which one is right for you.
Right.
I think that could be a little bit frustrating while you're doing physical therapy, especially if you're a trail runner. There's nothing like running on a trail that you could simulate in a physical therapy atmosphere.
There isn't, but that trail running requires a lot of eccentric loading on the foot.
Yeah.
Just because of the unevenness in nature of a trail. So that would just require like a lot of proprioceptive training and eccentric loading.
So what does that mean, proprioceptive training?
Proprioceptors are receptors in your joint, and they give sort of the rest of your body feedback about where you are in space.
Okay.
So it's really going to help with balance on uneven surfaces because your ankle proprioceptors are being stimulated to let you know what type of surface you're on.
Sure. Yeah, I'll see a lot of, when we talk about injuries in general, we'll often talk about chronic issues versus acute issues. And a lot of times you and I will both see acute ankle sprains.
Sure.
And so one of the most important things for that is proprioceptive training. So when you have a runner who has an ankle laxity or an ankle sprain, how important is it or how do you kind of approach the proprioceptive versus strengthening versus flexibility kind of phases of specific physical therapy?
So I think acutely, I think proprioception is just so important to just retrain, give the ankle some feedback. And then stability would sort of be the next on my list of like priorities. Because chronic ankle sprains, being said, become chronic,
of
right?
Course, yeah.
You have laxity in the joint. So stability and proprioception are just really important to retrain following that, whether it's static or dynamic.
Yeah. It's all, I mean, it's all super important, but I think the timing of different phases of physical therapy are just as important as the therapy itself.
Sure.
And so when the pain and the acute swelling is high, introducing modalities to kind of decrease the pain and inflammation, this is where, as physicians, we'll play a significant role in trying to get that inflammation down.
Sure.
And then working on the proprioception, the balance, the retraining some of the muscle groups, and then strengthening to the point where they're able to run again, pain-free is usually the last aspect of things.
And I think early mobilization in terms of like manual treatment, because that can help sort of desensitize the pain, help sort of reduce some of the swelling there as well.
Yeah, and there's more and more studies coming out that early mobilization for especially ankle sprains is key. We've known that for a long time with low back pain, rather than laying on the couch for 2 weeks trying to get up and do activities that's tolerated. Same thing with ankle sprains. The more you put weight on it and try to move it, the shorter the recovery time it seems like. And so I think early mobilization, early physical therapy is really, really the key for the duration of the expected course to healing an ankle.
Sure.
Now, one of the other risk factors that we'll often look at is training load. And this is more of the overuse type injuries that we'll see. So, I had a 17-year-old kid who's doing cross country training, really increased his load, started to develop shin splints. So how would you kind of approach more of a chronic issue or an overuse type pain issue with an athlete who wants to run more?
So I think the biggest thing is looking at their mechanics and how can we change their running mechanic to reduce the load. So typically in patients who want to return to running, who are having issues with this, I'll take a look at where are they striking? Are they a heel foot striker or midfoot striker? And what is their cadence like? Because both of those things are adaptable.
So what's a cadence?
Cadence is how many steps you're taking in a minute.
Okay.
So I think the biggest thing is I'll remember I played soccer in college, and as we're running around the track, I'll never forget my trainer being like, just stride it out. And I'm like, okay, and that's the thing, you just want to finish.
Right.
But the longer your stride, the more time you're spending in the air, which means the more force you're taking up as you hit the ground. So small things like increasing your cadence, which is increasing the number of steps that you're taking in a minute, would help to reduce the load. As you're running.
But it's extremely difficult, especially the marathon runners, the runners who have been running basically their entire lives to change their stride, to change their cadence, to change their foot pattern. So hard to do. I mean, they've developed those habits their entire life, and it just feels unnatural. How do you kind of break that cycle?
I mean, I think it's going to depend on the person. and where they're at in rehab. Like in the past, I saw a patient, he had a meniscectomy, avid runner, very reluctant to return to running because he's like, I don't want to predispose myself for arthritis.
Sure.
So it helps when they're a little bit more understanding of what's going on and the fact that they need to change, because he was very open to sort of cadence training. But I think runners also don't want to stop running. They're not the ones that you can really go in and like modify their exercise. So you kind of have to approach it from, we can keep you running if we can make these small changes. And you sort of just need to like appeal to what their goal is.
Unfortunately, you know, I've seen a ton of people training for marathons, the Philly Marathon, the New York City Marathon, who begin to develop stress injuries. And stress injuries it's a spectrum, right? So, you know, for the shins, for example, it starts out with MTSS or the shin splints. And then it progresses to a stress reaction, to a stress fracture, to a true fracture. And we'll often talk about, you know, these are overuse injuries, which means that we have to scale back on the activity. And then we'll often talk about, I want you to keep your cardiovascular endurance up through cross training. So, you know, advising for biking or swimming to reduce some of the mechanics that they're doing over and over again with cadence and running is super important. But I think aside from decreasing the load, which is a risk factor for injuries, correcting the mechanics that might have produced it in the first place, as you're pointing out, is paramount. It's so important.
And I think mobility is sort of key. The amount of people I see who don't really have ankle dorsiflexion, so like the ability to bring their toes up like towards their face. You're going to get the motion from somewhere. Your body's pretty good at finding out that path of least resistance. So again, all of these things are retrainable, and incorporating mobility exercises will help to improve the mechanics.
I think that's a great point. So in terms of improving mobility, besides, so stretching, everybody always asks about stretching before or after running. What type of stretching? Should it be static? Should it be dynamic? What are your thoughts on stretching and mobility?
Prior to activity, I think dynamic stretching is the best way to go.
And what's the difference between them?
So static stretching, you're just literally standing, static, just getting elongation of the muscle.
Bending down and touching your toes and just staying there for 10 seconds, right? You know, your static stays the same.
And I think dynamic warm-up just prepares the muscles a little bit more. Because you're getting more motion involved in it. So,
things like heel kicks or you know, straight leg raises, where you're elongating the muscles, but you're moving them. I think that, so they've done studies where it shows dynamic stretching is superior to static in reducing injury and getting better flexibility. People also do ballistic stretching, which is a huge no-no. Which is basically where you're bending down and touching your toes and you're trying to bob back down further and further and further. Studies show that is actually will
good
increase your
risk
for injury. You know, I always recommend doing an appropriate warm-up before any activity, So 5 minutes to get the blood pump in, the heart rate up to a reasonable level, and to stretch out the muscles through dynamic stretching. But then I also recommend a little bit of stretching afterwards, usually more static, just because people are tired after a strong workout.
I prefer like foam rolling, so myofascial release, because in that regard, there's so much fascia throughout the body. Fascia is a layer of soft tissue that covers muscles, helps to give them their shape, and it's throughout our whole body. So we also have different fascial bands that might go across your body, and fascia can also lead to a lot of restriction as well. So foam rolling you get the most bang for your buck in terms of being able to make effective changes to both the fascia and the muscle.
So when you do foam rolling, I mean, everybody thinks, especially with runners, the IT band. Where else can you how do you do foam rolling, I guess?
So foam rolling is great because you can get your quads, so the front of your thighs, your hamstrings, the back of your thighs, IT band. So it's going to require you getting down on the floor. and if you're running, arguably you can do that.
Yeah.
But there's also this other tool called the stick.
Yeah.
It almost looks like a rolling pin with like a lot of
exactly
little
what it looks like,
notches.
yeah.
So you can really get into the different layers of soft tissue there and literally just roll your muscles out as if you were rolling out dough.
Okay.
And you can get shins.
Yeah.
You can get your calves. You literally can
get
roll out
anywhere.
anything.
Yeah.
Yeah.
It's I think it's a great way to kind of release some of the fascia, as you're saying, loosen up some things. We'll often do, I'm an osteopathic physician, so I'll often do manipulations directed at the fascia, some soft
Sure.
tissue releases with the exact same principle in mind, to help reduce some of the restriction,
Yep.
help with mobilization, which should help reduce some of the pain that they're having.
Right.
I think it's really important to, when you're doing any kind of exercise, running in particular, to do an appropriate warm-up, followed by the activity, followed by the appropriate cool down.
Cool down.
Yeah.
Oh, for sure.
Yeah, really, really important. What other kind of running specific injuries will you see and kind of work with more of the elite runners, the half marathons, Ironmans? What will you kind of see?
So sometimes we'll see Achilles tendonitis, which is heel pain, so irritation to mostly I'll see more insertional Achilles tendonitis.
Right.
So irritation at where the Achilles attaches to the heel. And sometimes IT band syndrome.
Yeah.
Not as much as the Achilles.
Yeah, the Achilles, and that's a tricky one.
Yeah.
Because that lingers for a long period of time.
Yeah.
We know steroid injections are not good for Achilles tendinopathy or
Right.
tendonitis, because it actually can predispose or cause rupture of the Achilles. There's some good evidence behind PRP injections,
Sure.
Prolo injections, percutaneous tenotomy, but those I think are really more of second line after you work out the mechanics and see why did you get Achilles tendinopathy in the first place.
Right.
So what will you often see with Achilles tendinopathy? What are some of the mechanics that may predispose an athlete to develop it?
So I'm going to take a look at a couple things like toe extension.
Okay.
You need like 70 degrees of toe extension for push off.
That's a lot.
Which is a lot.
Yeah.
So if you're not getting enough great toe extension, like I said previously, like you're going to get mobility from somewhere else.
Yeah.
It could also be plantar fascia restriction as well.
Sure. Yeah.
Not just restriction at the joint for toe extension.
Right.
So taking a look at some things there. And then I'll also, in runners, I also look a lot at the pelvis, to be honest. Is there sort of an innominate rotation at the pelvis, which would mean, is there like an asymmetry?
Right.
Because an innominate rotation and being asymmetrical is going to alter sort of the length tension relationship between muscles.
Yeah.
And then you can get inhibition of your glutes. We need our glutes to fire for running.
Of course.
So
And it's frustrating or difficult for some athletes and patients to kind of look at the whole body as a unit, right?
Right.
When you start looking at their pelvis and their glutes firing and do a Trendelenburg test, they'll say, why are you looking at that? My ankle hurts. Why are you looking up here?
Yeah.
It doesn't make any sense. But it makes
Yeah.
total sense if you understand the anatomy and the physiology behind all the muscle groups.
Sure.
And so, it's one of those things that we always look for as physicians too.
Sure.
Again, going back to the theory or the statement that the whole body's a unit, right? We're not just the sum of our parts.
Yeah.
It's important to evaluate and look at the whole body to make sure that there's no stone left unturned in
Right.
terms of the mechanics of why did you get injured in the first place.
Right. And that's what I explain to the patient too. Like we want to look for the driver of pain, like an overuse injury, like a tendonitis, tendinopathy. Those things are secondary symptoms.
Yeah. They didn't occur overnight. That's not an acute issue.
Right. So what is driving that pain? And that comes down to educating the patient too on your exam, like why I'm looking. I personally try to talk through my exam with the patient and let them know why I'm looking at the things that I'm looking at.
Yeah, it's really, really important to communicate every step of what you're doing.
Yeah.
I think we covered a whole lot in terms of just generalized physical therapy, sport-specific physical therapy, and using the example of runners with a couple of different types of pathology that you and I both say.
Yeah.
Is there anything that we kind of miss or we think that the listeners and the viewers should know about in terms of therapy? I think we hit a lot of things.
We did hit a lot of things, and I think the sort of take home is that we're looking at a whole body approach here.
Yeah.
And I think that's the most important takeaway for everybody to understand.
Yeah, and I certainly have that same kind of mindset, and that's why I think that's why I refer a lot of patients to you, because I know that you have that mindset, and a professional PT, they always have that too.
Yeah.
So I think we're on the same page here, and I think that patients should be treated that way.
Yeah, absolutely.
So Nicole, thank you so much for joining me today.
Yeah,
I
thanks for having
appreciate
me.
it, and come back anytime.
Yeah, thank you.
All right, thanks.